The thoracic surgery group did almost 2,000 cases last year. This is the main campus volume. It does not reflect the growing work being done at Hillcrest, led by Andrew Fesco, and truly a thriving practice that has become a pop-off valve as due to our resource limitations. It's pretty impressive that we did 2,000 cases in 2 rooms, so 1,000 cases per room. Beat that. We also have a fairly wide breadth of exposure, which is an excellent for our educational efforts, and really creates a high-quality trainee when we're so proud to be able to do so. When we look at the types of pulmonary resection, which is the initial data that I will present, really to put this in perspective, we started back 11 years ago with this slide completely reversed. Roughly somewhere around 10 to 15% were minimally invasive surgeries, and 80-90% were open, and now that's completely reversed. The vast majority of our cases are now done by a minimally invasive technique, and this is really the national standard. Still, we're doing some open surgery, and that's really of an essence, and it's actually one of the efforts we've been making is to encourage actually open surgery and not use minimally invasive tools as an end. It is a means to achieve a good result, but an open surgery sometimes is good judgment. When we look specifically at lobectomy, interestingly, this slide is a bit dated because lobectomy is now kind of waning as far as the standard of care in pulmonary surgery. We still are doing a large number, roughly 200 to 250 lobectomies per year, but that number is dropping primarily due to the increasing use of segmentectomy as an alternative to lobectomy for lung sparing purposes. These are done again largely by minimally invasive techniques, as you can see on the slide, and those numbers are continuing to improve. When we look specifically at stage 1, which is roughly 60 to 70% of our surgeries, 95% of those are done by minimally invasive procedures. So again, this is the standard of care nationally, and this is the expectation patients should have coming here, that they get a minimally invasive surgery with an outstanding result. I'm cycling. This is what in the past 3 years, there have been 2 large trials that have shown equivalence, at least, of segmentectomy in relation to lobectomy for small peripheral cancers. Therefore, there has been a large push towards embracing that, yet doing so in a cautious manner. I think we still have much to learn about it. I think there are some groups that are chasing the shiny object and kind of forgetting the cancer theory behind the use of this technique, and I think we're doing a very responsible job of applying it when appropriate. Our length of stay for following pulmonary surgery, and specifically lobectomy, continues to decline. We've hit an inflection point, and basically all of these programs, essentially what has happened, I don't know why it keeps cycling back. The national standard has now gotten down to about a median of 3 days. So what we're seeing now is a reflection of outliers there that are affecting the mean here. And so this is seeing this inflection point, this crossover has raised some new possibilities for us looking at our outlier numbers and who are those patients. And this is kind of going to be one of our new quality projects. In the thoracic surgery literature, they don't declare mortality rates, they declare freedom from mortality rates. And you can see the top number there is the best performance in the SDS database, and the black line, the blue line is our program, and the dotted line is the 75th percentile. We had the lowest risk-adjusted mortality rate in the SDS database this year for pulmonary surgery, and I want to congratulate our entire team on that. It's an excellent accomplishment and something that we can brag to our patients about. This translates into a 0.1% mortality rate for pulmonary resection for lung cancer. We've achieved a 3-star ranking yet again. Mark showed that slide earlier of 3 stars down the boards. that you will not see anywhere in the country. And the 3-star has become kind of standard. They got a 3-star. Most places write a paper when they get a 3-star ranking. So I think this is testament to the system that we work in all of the amazing people in every aspect of patient care that can rescue patients and provide tremendous outcomes. Now on to esophageal cancer. Siva didn't want to talk about that. As I said, that's roughly about a third of the practice, and that's actually a growing part of our practice. The esophageal surgery for the STS registry, which includes major esophageal cases, is growing. And the volumes, when we look at the breakdown of the program, again, there's this wide breadth of benign and malignant disease that is unusual in most places where there are high volume cancer programs and high volume benign programs, and yet we have both. Outcomes are, as typical, excellent when we look at complication rates in our esophagectomy population. Our achalasia practice, this is an interesting one that Siva can wax more poetically about, but achalasia has, Siva's built a very large practice off of the shoulders of Dr. Rice, who had attracted a large achalasia population to the Cleveland Clinic, and has championed less minimally invasive means and now endoscopic means using the POEM surgery, and he now has POEMs day every other week, where he does 4 or 5 POEMs in a day, and that's truly an amazing practice. Again, setting the bar for mortality for esophagectomy. The black line is the best performance in the country. Blue line is the Cleveland Clinic. Dotted line is the 75th percentile. Basically, our esophageal program defines the best performance in the country. And has again achieved a 3-star ranking. Another 3-star. So I just wanted to say thank you to everyone in our group. We've really achieved some amazing things, and we happy few, as Henry V said on the Battle of St. Christmas Day. I'm just very proud to be amongst this band of brothers and sisters. Thank you.